and welcome everybody to Medical Myths, the show about what not to do with your body. And yes, I'm seeing people say that Bree made them come here. And yes, I appreciate that Bree made you come here. Everybody subscribe to Bree. And I apologize for the dog screaming in the background. They're playing out in the hallway. But we are here, everybody, talking about everyone's favorite subject, abortion rights. And this isn't anything new. We're not really covering any kind of urgent recent news story other than the fact that uh, this current administration continues to want to not allow abortion. They are very pro life, if you will, although they do not care about anybody outside of the womb. And we're seeing with the trans community and with the administration's recommendations for continuing this global gag rule, as we're calling it, which was originally kind of established during the Reagan administration, which penalizes other countries for engaging in these standards of care. So we're seeing this becoming an issue, especially related to trans rights. So countries that are providing gender affirming care are risking penalties from the US to try to silence that. Similar thing kind of happens with abortion. So that's primarily during the Reagan administration. That was the key issue of the global gag rule was abortion rights and not wanting to support countries that that recommend legalized abortion. So we are here today covering kind of a crash course about pregnancy related topics, discussing what is abortion, what are some of the nuances about abortion. I have literally about 30 something tabs open. So I am not sure exactly what directions this stream is going to go into. If we miss anything, we can always come back and do more content like this. I'm sure this issue is not going to go away anytime soon. Thank you, Bree, for grabbing the dog. I appreciate it. I know he's just having fun out there. But we're going to talk about, what are the differences between abortion, pregnancy termination, what is the difference at different stages of development. We're going to talk about different methods of pregnancy termination and concerns that the political right has with those things and what myths they're perpetuating. And then, of course, with all of this, we are citing the American College of Obstetrics and Gynecology. I am not a gynecologist or an obstetrician. I have managed pregnancies under supervision of OBGYNs, but I am not an expert in that field. We are, of course, deferring to those experts. If you'd like to know more about this, if you want any of these articles, you can go to ACOG's website and find really all of this for yourself. They do a really amazing job at communicating to the general public about abortion related topics and about pregnancy related topics in general, as that is their medical specialty. But let's dive into this. Oh yeah, comments in the side chat about the dog. All right, so let's get into this. So it's important first to understand terminology, what we're talking about with regard to stages of pregnancy, because a lot of the myths stem from a misunderstanding of what is actually happening medically, a misunderstanding of the terminology that is used. And it's very easy to spread misinformation when we're not even speaking the same language. So that's going to be the start of this whole topic. So we have here on the screen, we have a chart for the weeks of gestation. And then on the side, you have a downward arrow showing kind of the increasing morbidity for earlier stages of pregnancy and increasing numbers going up in the up arrow, showing that, the farther along the pregnancies are, the more likely the fetus is going to survive, but also that the majority of pregnancies are going to be concluded closer to full term for a full term delivery. So we have here kind of, it doesn't go all the way to the beginning of gestational age, starting at kind of 22 weeks. But there's some kind of disagreement depending on what country you look at for what they define as the age of viability. So, and that's going to influence the terminology that we use and how we are delineating what is an abortion and what is not. So, in the United States, it's usually thought of that between 18 and 20 weeks, that is the threshold to where we're getting into a more viable stage of pregnancy. So, most of our terminology is going to hinge off of 20 weeks. That is going to be kind of the big time that everything bridges over. However, we'll get into why using that black and white can also be kind of problematic. But when we talk about the term abortion, that is with regard to the status of the pregnancy and not at all referring to the status of the gestation or the fetus. So it's important that when we're talking about this, if you hear people using language like aborting a baby or aborting a fetus, that's not really correct language that we want to use because that puts a framing onto this that the gestation is a baby, is alive, has, and then that's how we get to a lot of arguments about them feeling pain, them being killed. So if we say uh, aborting a baby, that gives you an emotional way of thinking about it. It makes you think a very specific thing. Whereas we should be saying aborting a pregnancy or terminating a pregnancy. So that's very, very important that we get that piece right. And this is similar to when we're talking about arguments related to gender affirming care, because a lot of the rhetoric used by pro life people and by, I got to stop saying pro life, the forced birth people, forced birth uh, talking points are very similar to anti trans talking points in that they frame it in the most egregious way they can think of wording it, right? So if we compare this to gender affirming care of minors, people get very, very up in arms about care for minors, not understanding that the most common form of gender affirming care we give is therapy and letting people dress however they want and wear their hair however they want. Like social transition and therapy are what the majority of trans minors are going to get. But the anti trans arguments are going to hinge on either very fringe cases of people getting surgeries at younger ages or puberty blockers, which are very benign medications, but them being able to focus on, oh wow, they're getting a medication, they're getting a surgery at the age of a child. Okay, well, technically, you could call a 17, 18, oh, well, not an 18, a 16, 17-year-old a child because they're still a minor. But when you say the word child, people oftentimes think of a 5-year-old, a 7-year-old, a toddler. So that's a way that they can use the language to frame the narrative and to make you think a certain way. So then, of course, people are going to say, well, I don't want my toddler getting top surgery. Well, that's not happening. That's not at all happening. Uh, Especially toddlers are not in that stage of development where we're worried about them growing breast tissue, etc. But that would be a way that they can make an argument. So it's the same thing here with abortion arguments. So a question from Miranda. So would it be different in a less developed country where they don't have NICUs to keep younger preemies alive? Yes, it actually does differ. It does differ because it is the definition is dependent on the technology of the country to care for premature infants. So that is absolutely a factor. So if we think about 20 weeks being kind of the accepted stage of viability in the US, and abortion, by definition, is the ending of a pregnancy prior to 20 weeks. So if we think about that, that encompasses two different things here. So we have what we call a spontaneous abortion, which is a pregnancy that ends itself prior to 20 weeks. That's also known as a miscarriage. And that is, of course, unintentional. There are a lot of people that have miscarriages. It's a fairly common occurrence, becoming, less so with our ability to detect conditions that may predispose people to have miscarriages more often. But regardless, we cannot prevent people from, we cannot eradicate miscarriages. They're going to happen. So that is a form of abortion, but it is a spontaneous abortion. The other side is a non spontaneous abortion, also known as an induced abortion, which is where there's a medical procedure, whether that be a surgery or whether that be a medication, that causes the ending of a pregnancy prior to 20 weeks. So that is the technical definition for abortion. Although, if you go to the WHO, they have their definition of abortion actually quantifying this down to the ending of a pregnancy when the gestation is 500 grams or less, which puts it roughly around 20 to 22 weeks of gestational age. So, that kind of quantification isn't as useful. I don't think people are going around measuring the weight of their gestation in grams. So that's kind of more of the theory behind this. But we'll stick with the definition that an abortion is the ending of pregnancy prior to 20 weeks gestation. Anything after 20 weeks gestation is a delivery in some form. So, what we're really talking about uh, with an induced abortion, or just with the abortion conversation in general, it's more useful to use the phrase pregnancy termination, because termination implies that there is a non spontaneous ending of pregnancy. So anything that would cause somebody's pregnancy to end is a termination. And so this can be intentional for medical reasons, it can be intentional for personal reasons, and it can be at any stage of gestation. So a if we go back to our terminology for abortion, a non-spontaneous abortion is a form of pregnancy termination, of course. But if we look at later on in the pregnancy, let's say somebody needs to end their pregnancy for a medical reason at term. So let's say somebody has preeclampsia, or even just somebody, let's say somebody carries their gestation to 41, 42 weeks. If you end the pregnancy by any means intentionally, at any stage, that is a pregnancy termination. So somebody who has a C-section is having a pregnancy termination. Somebody who has induction of labor has a pregnancy termination. So let's say somebody gets on the schedule with their OB and says, yeah, I don't want to carry this pregnancy beyond 39 weeks. I think 39 is kind of often the earliest an OB will do an elective induction or an elective C-section for like a non-medical indication. But in that case, you are terminating the pregnancy, but the fetus is still alive, and the goal is to keep the fetus alive. So if somebody has had a C-section and they're against uh, elective terminations of pregnancy, you can bring that up and say, didn't you have a C-section that you willingly ended your pregnancy, but the baby still lives? So that's just to point out, just because you have a termination does not mean that the fetus is going to have demise. Right. So we have to separate out what is a result of the procedure and what is the result of, fetal demise after that. Is it an issue with fetal viability? Did we do this procedure at an early age where you're not really expected to survive after the delivery? Or is there something that can be done to keep the gestation alive outside of the uterus? So that's a few things that I want us to consider very closely as we're going through this rhetoric today. But back to this chart here. So we have the weeks of gestation. We've established that 20 20-ish weeks is kind of the stage of viability. But if we look here, this is also very, very important, is understanding what we mean by term. So there are arguments that we will get into today about wanting to ban late term abortions. And so this can be a little bit misleading and unclear because when we say term or late term in a pregnancy setting, that has a very different meaning than how a lot of pro forced birth people will use that term. So it's important that we get these definitions right. Ember, yes, you are making a great point. The conflation then is between the procedure on you with the outcome for the embryo, which is properly a different thing. Absolutely. Yep. When we are talking about the procedure, we are talking about the ending the state of pregnancy, not at all having anything to do with the status of the fetus. So if you get in discussions with people about abortion rights, ask them about these definitions. Ask them how much they know about it. Because if they can't accurately define what we're talking about and understand the differences here, then I don't really want to hear their opinion about what medical care somebody else should be allowed to access for their pregnancy. But back to the kind of the term status. So we have here, it used to be the case where we would label gestation as full term or preterm, but now we have a lot more categories here to further risk stratify. So if we have somebody who is going into labor, whether spontaneously or non spontaneously, we can better predict what type of care the pregnant parent is going to need and what the gestation is going to need at that time. So we have full term is usually accepted to be 39 to 41 weeks gestation. Anything after 41 weeks is post term. And at that point, you're reaching a lot, like a really high risk of complications, high risk of hemorrhage, high risk of needing a C section. So usually we want to get the baby out somewhere between 39 and 41 weeks. So 39 to 41 is this full term category. Between 37 and 39 weeks, we are at early term. So as we approach, 38, 39 weeks, the fetus has very high likelihood of survival. So if you have any medical reason or personal reason that you need to evacuate the uterus, you can usually do so pretty safely for both parties. 37 weeks can be hit or miss. There are some medical guidelines that would say you need to terminate the pregnancy at 37 weeks. That would be something like preeclampsia without severe features. You're going to want to get the baby out kind of as soon as those features start to develop, because any longer stay in the uterus can lead to higher risks. So 37 weeks usually is more of a medical indication unless, it's a spontaneous delivery and the person's popping out a baby right then and there, then there's not much you can really do about that. So for medical reasons, 37 usually not a huge deal. Earlier on, we see 34 to 36 weeks. We're calling that kind of the beginning of the preterm stages. So that is late preterm. There are medical indications for delivering a gestation between 34 and 36 weeks and with the intention of keeping them alive. Usually this is for very, very severe conditions that need you to evacuate the uterus right then. That would be eclampsia. Like eclampsia, I mean, just you need to get the baby out as soon as possible, even if you're early on. So eclampsia, to clarify here, preeclampsia and eclampsia are on kind of the same spectrum of medical conditions in pregnancy, all related to high blood pressure. And essentially, what happens is you have kind of malformation, or at least this is the running current working hypothesis, is that there's malformation in the blood vessels connecting the placenta to the uterus. And so, in that case, it's difficult for the gestation to get nutrition and blood flow. And then it also causes high blood pressure in the pregnant parent because that blood flow needs to be able to transfer over into the fetus, because you have higher blood volume when you're pregnant. So you need to be able to have that exchange. But if you don't have proper exchange of blood flow, you can get some extravascular trauma, higher risk of the blood vessels getting smaller and tighter, higher pressures. And with those higher pressures, you're risking neurological problems, liver problems, and those can lead to death. So we see in eclampsia specifically, that's where you start having seizures because your blood pressure is too high. And so that can be fatal. So in that case, ACOG says to deliver, just deliver the baby. Like, it does not matter what stage of pregnancy you are in, just deliver. But if you have preeclampsia, so you're not having seizures yet, but you have very severe features, so high risk of parental mortality, that's a case where you may need to induce the delivery between 34 and 36 weeks. So while less comfy for whoever is doing the delivery, it can be done and is recommended to be done under certain conditions. 32 to 33 weeks, they're calling moderately preterm. 28 to 31 weeks, very preterm. And then anything earlier than 28 weeks, they're calling extremely preterm. So there are some conditions that could make you just have a spontaneous delivery at any one of these stages. It's very, very unlikely that you're going to induce a delivery at this time unless there is some kind of very severe malformation in the fetus, or if there's a very, very, very severe complication in the parent. So this is where it's important to iron out late term abortion, which is not a term that's really being used anymore. And I know I'm kind of throwing a lot of terms y'all's way, but I wanted to clear up these definitions before we dive into some more of the rhetoric. So a lot of people will use the term late term abortion to describe a termination of pregnancy after 18 weeks of gestation or after 20 weeks gestation. So that is not, by definition, that is not late term. That is very extremely preterm. So don't let that be confused with terminating a pregnancy at full term. Right. So there was this argument that was given by none other than Donald J. Trump, I believe, in his first election, where he said that they're aborting, they're killing the babies like while they're being delivered, or like at the time of delivery, or the quote was moments before the time of delivery, which is absolutely ridiculous. And that is a misunderstanding of what the term late term abortion means and why we no longer use the term late term abortion. Because let's think about this critically for a second. If what we just said was that abortion or termination is the ending of pregnancy at a certain point, and termination being a non-spontaneous ending of pregnancy at any stage, what would it mean to end a pregnancy moments before birth? That would literally just be moving the time of birth minutes earlier. That's all that would happen. That just means you were in active labor and you start crowning sooner than you thought you were going to, or if you were going into a C-section, it just means that you delivered the baby minutes before you spontaneously would have. And in either case, you're going to end up most likely with a fully alive baby that the parents want to have. And Ember's point, after delivery, even, that's completely nonsensical because you can't end a pregnancy that's already over. Like, that is just completely nonsensical. So when they say late term, we're actually talking about extremely preterm, in that beyond 18 weeks gestation. And that is a completely, completely different question. And yes, I'm going to admit that there's some legal stickiness if you get into the nitty gritty of what are medical indications for termination at those earlier stages. What are these procedures that are being done? What are the safety risks and all that? Which is where we then have to fall on a bodily autonomy argument, which we're not going to super focus on today. We're mostly talking about uh, the medicine behind all of these. So I apologize for all of that kind of jumbled all together. I think now that we have our definitions cleared up, we can get into some more of these specific arguments. I did want to maybe read this paragraph talking about the different stages of gestation, just to give it a little bit more context to this. So they say the days of considering preterm and term birth as a simple dichotomy have gone. More complex subcategorization across the spectrum of gestational age has now been almost universally accepted and reflects messages from research studies that tell us of a gradient of risk associated with decreasing gestational age at birth, which is true. We have recognized for many years the hugely increased risk of poor health and neurodevelopmental outcomes that comes with birth at the margins of viability. And the concept that every week matters for preterm babies is very familiar. However, we've taken considerably longer to explore the outcomes of more mature babies and to discover and subsequently accept results from increasing number of studies that indicate this applies not just to babies born at the lower end of the spectrum, but at the gradient of risk extends not only through the preterm range, less than 37 weeks, but right up until full term, 39 to 41 weeks. Perhaps we should not be surprised, after all, babies born at 34 weeks used to be the sickest, with survival below that gestational age being unusual. So, and that's true. So, kind of before we've improved our medical management of preterm deliveries, it used to be, before 34 weeks, you're pretty unlikely to survive. And it's still the case where it's very high risk that babies are not going to survive if they are born before 34 weeks. However, our science has greatly improved. And I've actually taken care of babies that were born at 23 and 24 weeks. And as far as I know, they are still doing okay. They have significant chronic health issues and probably will for the rest of their lives. For example, they're mentioning here in this paragraph that John F. Kennedy's baby son, who died of preterm lung disease just a few days after his birth at 34 weeks gestation, we know that in order to survive outside of the uterus, you're going to need to produce surfactant, which is produced by developmentally more mature lungs. We know that gastrointestinal issues are very common because in utero, you don't need those tissues to work right away. So it takes longer for your DNA to kick in and to say, we need to start producing tissue that can digest breast milk and can develop to digest other foods after that. So those systems that aren't really utilized in utero aren't going to be as mature and not going to be able to sustain life outside of the uterus. So in that case, you are risking a lot of chronic lung disease. You're risking GI issues. You're risking need for feeding tubes, and even possibly lifetime use of feeding tubes, just because you won't be you're not able to digest food. So we do know that longer gestation is beneficial for the most part, but there are cases where either a health reason causes you to need an induction earlier, or need a termination without the intent to preserve the life of the fetus at those earlier stages, or just a spontaneous delivery that you can't really prevent. So so this can happen, but not every fetus that is born at 23 weeks is going to have positive outcomes. So I'm not denying the fact that fetal demise is common in these stages and oftentimes expected. But this has to be a conversation with all parties, and you have to factor in risks and benefits and your own, and not even just medical risks and benefits, but your own socioeconomic risks and benefits, your own the risks that you're accepting for your own body. Those are very, very important factors to consider when deciding, do we need to induce a delivery super early on? So let's head over to, I think let's pull up, where is it? Let's pull up just kind of the myths, the general myths about abortions. Okay. So this stuff we probably won't take too long to address because I feel like a lot of you understand these particular myths. We'll get into some more of the nitty-gritty details about later abortions. But the first myth on this list is that all abortions are voluntary or planned. And of course, I think a lot of you know that this isn't the case. In fact, the term abortion is actually a medical term used to describe the end of a pregnancy, regardless of how it happens. Absolutely. That's what we just said. What many people think of when abortion is being discussed is elective or voluntary abortion, which is performed at the person's request for non medical reasons. However, very, very few abortions fit into this criterion. And here are some of the exceptions. So, termination of pregnancy, like we just mentioned, um, can be done for uh, preventing harm, increasing the likelihood of survival, and addressing, risks of physical, psychological impairment or increased chances of terminal illness or death. So that's more of a medical abortion. Another term that we use to describe this is therapeutic abortion, which is performed for the sake of the pregnant person to prevent harm to the physical or mental health. So we, like we are saying, with chances of terminal illness or death or physical impairment, etc., that is included in therapeutic abortion, but also in cases where somebody does not have um, the mental support system or has some chronic mental health conditions that would make it more difficult for them uh, to number one, carry a pregnancy to term or to raise the baby after the birth. So that is something that we consider as well. So especially, let's think about an example real quick. So if somebody um, has an unintended pregnancy and they're taking uh, medications for mental health reasons, let's say if they're taking like a mood stabilizer, maybe, or if they're taking some antipsychotic medications. Some medications that are used for psychiatric reasons are appropriate in pregnancy and are demonstrated to be safe. Uh, Antidepressants are largely considered to be safe during pregnancy. However, not all medications are going to be safe. So let's say if you have somebody who has very high safety risk because of a mental health condition, and they need that medication to stay alive and to stay safe, that puts that person into a bit of a bind. If they have to say, you have to make the choice of whether you're going to continue this medication or if you're going to carry the pregnancy to term, that is a risk that only that person and their doctor can make. And even regardless of what the doctor thinks, the doctor can give the recommendation, but that is up to that person on whether they want to accept that risk. Another very, very big example is with trans people. So it is a fact that testosterone is a teratogen. It can cause mutations and very significantly lethal mutations in the fetus. So if you have somebody who is trans and is taking testosterone therapy and has an unintended or even intended pregnancy, they have to make a choice of whether to continue with their testosterone therapy or to stop that while they carry the pregnancy to term. And there are plenty of trans men that want to get pregnant and they want to carry a pregnancy to term and they want to deliver the baby and raise the child as their parent. And that is totally fine and that is totally that person's choice. But there are also people who would not have good safety outcomes if that were to happen. There are trans men who, if you take them off of testosterone, they can have mental health crises, they can have physical health crises, they can have uh, some of their like the risk of some of their transition gains start to like decrease. Like their ability to pass in public might decrease, especially as they are pregnant. Like, having a visible pregnancy would make it very difficult for a trans man to pass in public. So that could present a risk for violence in public. Like, all of these are reasons that need to be considered when thinking about carrying a pregnancy all the way to term and having a delivery. And so the options need to be present in order for people to make the best decision for themselves. So just because someone's carrying a pregnancy to term does not mean that they are going to be safe, and that the gestation is going to be safe. Um, and another factor is this idea that pregnancy is just a benign thing, that people, well, number one, just the idea that a lot of religions especially will perpetuate is that pregnancy is expected. And like we were talking about in Bible study this week, on Ember's show, that having a pregnancy is kind of a metric for being seen as a woman. And so many people may feel like they have to get pregnant, and they don't really talk about what the risks of pregnancy are. And pregnancy is not a benign condition. Even if you have a completely uncomplicated pregnancy, it is still high risk because anything can happen. And especially the risks are going to go up the farther along in the pregnancy you go. So the closer you get to term, the higher risk you're going to have of developing something like preeclampsia. Things like postpartum hemorrhage is one of the most common causes of maternal deaths worldwide. And that is where you have uncontrollable bleeding after pregnancy. And that's a big reason why people may need a hysterectomy after their pregnancy. So it's important that people have the ability to make decisions long before they get to that point. So having an earlier abortion is going to be safer, much safer than even the risk of carrying a pregnancy to full term. Um, and so that's something that we have to think about as well. So, and then they talk here about spontaneous abortion, which we talked about previously. But they have a statistic here that spontaneous abortion occurs in 20 to 30% of pregnancies in the first trimester. So incredibly, incredibly common. And that leads into a difficult situation with enforcement. How are we going to enforce abortion bans when we have 20, 30% of pregnancies ending in miscarriage in the first trimester? How are we going to determine whether or not something was a miscarriage? Um, that could be a reason why people would be imprisoned or convicted of murder, in especially in states like Texas and Florida that want to impose abortion bans just outright. You could have somebody who is accused of having an elective abortion who really had a miscarriage, or if they have certain types of miscarriages that don't lead to the direct expulsion of the fetus, uh, you're asking for very, very severe consequences. Let's think about another example real quick. So there's certain factors that keep a pregnancy in utero kind of throughout the gestational periods. And one of these, of course, is the fact that the fetus is contained within a membrane, like this big amniotic membrane that contains amniotic fluid, and it contains the fetus, and that sits on top of the inner side of the cervix. And when you start to get later on in the pregnancy, and as you get closer to labor, you have what a lot of people call breaking your water. And kind of before that, you'll have this mucus plug that kind of falls out, and that allows the amniotic sac to get closer to the cervix. And this pressure, when you have the fetal head pushing on top of the cervix, you get cervical dilation. So the cervix is going to soften, it's going to dilate. And then once you get enough dilation, it's going to be a lot of pressure exerted on the amniotic sac, and it is going to rupture. And so we call this rupture of membranes, and that is when your water breaks. And the membrane is a very important protective feature for the gestation. And once that's broken, anything can get in. Like, you need that barrier to um, keep the gestation from getting all kinds of bacteria, um, and which can cause fetal demise, but can also cause parental demise. So the pregnant parent, can also die from that protection being taken away. So most of the time, you're going to have the pregnancy make it to term, and then you're going to have rupture membranes during a natural labor process. However, if there's something wrong with the fetus, or if there's something, a medical complication with the parent, or if there's something that happens, uh, I'm trying to be very careful with my words here, but if there's some kind of assault or something that happens where that membrane gets ruptured too early before labor, um, then we get what we call PPROM, which is an absolute emergency. So PPROM is preterm pre-labor rupture of membranes. And if you have that barrier gone, that fetus needs to be expelled from the uterus, because the longer it sits there, the more likelihood bacteria is going to go up into the uterus and infect the gestation and infect the parent. And then you can get what we call a septic abortion. And so, whether or not this fetus was alive at the time of um, this infection taking place, it's not safe for it to remain in the uterus. So, if we have something like a heartbeat law, we run the risk of having, let's say we got an ultrasound very recently of a fetus in utero at what, like 18 weeks, 20 weeks, something like that. You have a heartbeat that shows up on the ultrasound, but you have some reason why the membranes rupture, and now you have to get rid of that gestation. Um, that could be classified as murder in the states of Texas and Florida under those heartbeat bills. But in that case, that is a miscarriage. That is something. I mean, usually miscarriage is before 20 weeks, but it would be a non-spontaneous ending of pregnancy. In that case, that would result in fetal demise. And then that parent could be convicted of murder and subject to very, very severe punishment when it was not at all that person's fault. So having these very black and white criteria for what defines a fetus as appropriate to uh, remove from the uterus is very, very problematic. And that's why we need to abolish any idea that that's appropriate. We need this to be a discussion between the doctor and the patient, determining the benefits and the risks and what needs to be done about that. So, myth number two, you cannot have abortion past the first trimester. Yep, and so this leads into some of the terminology. I know we talked about late term abortion really isn't a term that we're going to use anymore. So we want to be more specific about our terms. So ACOG refers to an abortion or termination after 20 weeks gestation as a later abortion, or you can say second trimester termination. That would be appropriate. That'd be much more appropriate than being confusing and saying late term abortion when we're not talking about late term. So a later abortion or a later termination can happen in the second trimester, although this really is not happening in high amounts like the right wants us to believe. So a lot of people are going to say that, oh, people are just waiting to have these D&E procedures after 20 weeks. Well, no. Only about 1% of terminations occur after 21 weeks, which is still technically in the second trimester, but these are often for medical reasons or some other extenuating circumstances. A lot of times, if you're making it to these stages of gestation, most people have already made the decision in their mind that they want to have this pregnancy to full term. And even they might be intentional pregnancies, but something may have happened medically where it's no longer safe to carry this pregnancy, or something else happened in their life where it's not going to be safe to raise this baby once they're born. So it's more appropriate and less risky to do a later termination. So I actually have an article that I want to pull up talking about why do people need terminations after 20 weeks. So we'll get into this kind of segment talking about uh, later abortions. So actually, I'm going to pull up first. I'm going to pull up one about later abortion. Where is it? I thought I had one. Oh, here we go. Okay, I do. Okay, so science versus myths about later abortion. So they kind of hint on the legislation, saying legislators are disregarding scientific evidence and enacting legislation that codifies misinformation. These questions of the effects of abortion on clients' mental health and of fetal pain and fetal viability are three areas in which significant misinformation has been disseminated, and this misinformation has been used as the basis for new legislation limiting abortion. The scientific evidence, however, does not support any of these restrictions. So their first point here is that abortion is not linked to subsequent mental health problems. So that's an argument that's being pushed out a lot, is that people are having significant distress and regret after having abortions, and that is not really demonstrated in the evidence. So a number of states mandate that those considering abortion be counseled by medical staff that the procedure can adversely affect their mental health. This is literally just a scare tactic. Yet the scientific evidence of date disproves the idea that having an abortion is any more dangerous to a pregnant person's long-term mental health than delivering and parenting a child that they did not intend to have, or placing a baby up for adoption. Yeah, so this is an argument that's very, very important to address. So a lot of times when people are making this claim that having an abortion will increase rates of anxiety and depression in the pregnant parent, are not like they're talking about this unilaterally, as if like even if this was true, right? Even if there was risk that having an abortion could make you higher risk for anxiety disorders, you still have to compare this. Uh, what the fuck is a second term abortion? That is a very good point. It's not a second term; it'd be a second trimester termination. Um, this is a typo in the side chat. Sorry, trying to get too much into the questions. But if they think about this unilaterally and don't compare the risks of mental health issues from having a delivery, like and let's say even if they didn't have a traumatic delivery, if they didn't have an emergency C-section or something, if they had an uncomplicated delivery, they're still going to have to go through that very painful process, that very stressful process of delivering a baby and then raising and parenting a child that wasn't right for their situation. Let's say if they can't afford food for this child, they can't afford to be at home. They have got two parents that are trying to work. They can't afford health insurance. They are in a situation where having this child puts everybody at higher risk, including the child. That can cause a lot of mental health concerns for everybody. Now, everybody is at risk for uh, PTSD and anxiety and depression because they are having trouble existing as people. Um, but even considering that there are very, very high rates of postpartum depression, and that is something that we're working on improving. And we know that there are a lot of antidepressants that are effective for postpartum depression, and they're highly recommended now. But if we're comparing the almost non-existent risk of causing anxiety or depression disorders from having an abortion, compare that to the rates of postpartum depression, which someone is very likely to have after carrying a pregnancy to term. So, if you're going to make a claim that there's a certain risk, uh, please compare that risk to the alternatives in the situation. And then they get into the point about fetal pain. So this is a big one that we're going to focus some time on. So many states have restricted abortions after 20 weeks of pregnancy based on the assumption that the fetus can experience pain beginning at this gestational age. However, based on the best available evidence, the fetal capacity to feel pain does not develop until after the beginning of the third trimester of pregnancy, and it's unlikely that the fetus can experience pain until after birth. So I do have another article pulled up about this particular thing. So let me find this. Where is it? Um, oh, here we go. Okay. So this is from ACOG. It says facts are important, gestational development and capacity for pain. So going into the same concepts that the other article was sharing, but a bit more in depth. So they say, here, I'm going to zoom in a little bit. The science conclusively establishes that a human fetus does not have the capacity to experience pain until after at least 24 to 25 weeks. Every major medical organization that has examined this issue and peer reviewed studies on the matter have consistently reached the conclusion that abortion before this point does not result in the perception of pain in a fetus. Rigorous scientific studies have found that the connections necessary to transmit signals from peripheral sensory nerves to the brain, as well as the brain structures necessary to process those signals, do not develop until at or after 24 weeks of gestation. Because it lacks these connections and structures, a fetus or embryo does not have the physiological capacity to perceive pain until at least this gestational age. So, whether or not there's a presence of a heartbeat or reflexes does not mean that the pathways necessary to perceive pain are even present. So that is a false uh a false argument in general right there. Um and they go further into discussing that pain is a complex phenomenon. The perception of pain requires more than just mechanical transmission and reception of signals. Multidisciplinary experts on the subject define pain as an unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage. The experience of pain requires conscious recognition of a noxious stimulus. This capacity does not develop until the third trimester at the earliest. The evidence shows that the neural circuitry necessary to distinguish touch from painful touch does not, in fact, develop until late in the third trimester. The occurrence of intrauterine fetal movement is not an indication that a fetus can feel pain. Exactly. Whether anesthesia, analgesia, or paralytic agents are administered to the fetus during fetal surgery is a distinct question from the capacity to experience pain. Yeah, so there is a question kind of about when they're doing fetal surgeries, like intrauterine surgeries. There's a question of how much anesthesia is necessary, or paralytic agents or analgesics are given to that fetus for the purpose of that surgery. How much of that is based on the actual necessity for these medications or the ability to feel pain, compared to how much of that is we assume that this is necessary because we perceive pain and we perceive the humanity of the fetus in a certain way. Therefore, we're going to make our guidelines accordingly. So it's really difficult to, like, you can't really ask a fetus like if they feel pain, right? You can't. It's like with a person outside the uterus, if you're gonna give them a procedure or a surgery, it's pretty easy to tell. Like, are they unconscious? Do they feel what's going on? Are they numb enough? All of that. Like, if you go in for a dental procedure, it's easy to say, okay, did you feel this thing? You can't do that with a fetus. Um, so we can't really make these assumptions about what a fetus feels. What we can really do is objectively determine what stimuli can they process based on what we know about the brain regions, based on what we know about the formation of these structures and what experience that that's going to give them. That is what we can determine. And there's no evidence that the fetus has any of these structures present to feel pain at any of these points that we're going to be doing a pregnancy termination without the intent of keeping the gestation alive after birth. Um, Sound policy is best based on scientific fact and evidence-based medicine. Which, funny enough, so we've got this topic of evidence-based medicine that we talk about every single week, and you have an administration right now trying to make America healthy again and say that they're relying on gold standard science, meanwhile completely rejecting gold standard science. Right. So that's just become an absolute dog whistle for anti-intellectual bullshit. But alas, here we are. So gestational age bands alleging concerns about fetal pain reflect a misunderstanding and misrepresentation of the science of gestational development and viability. I have another article that's very similar about this, although I don't know if I need to pull that one up. So now that we've established that fetal pain isn't really a consideration that we need to make, let's talk about why people undergo second trimester terminations. So I have an article highlighting the procedure that is done at this stage of gestation, and then I also have an article addressing why people seek these out and what's contributing to all of that. So let's go for a little bit of the um, medical side of this, of what exactly is done. And this is probably one of the more contentious points of termination. So it is, how do we go about these? And the most common method for termination within the second trimester is a dilation and evacuation, or a D&E. And this kind of highlights the risks and benefits of all that. So this is this and another procedure known as uh, manual vacuum abortion, or sorry, manual vacuum aspiration abortion, is, or the MVA is what we're going to call it. That one and the D&E are both the procedures that the right likes to utilize to suggest that this is a brutal process. So if you've heard the arguments that, well, they are ripping they're going in with forceps and they're crushing the head and they're ripping the fetus apart and taking pieces out, that is an absolute exaggeration. And yes, there are procedures to remove the fetus. This does not require you to crush the head or completely dismember the fetus. In fact, doing those things can make the procedure a lot more difficult, because you can have health problems after if you accidentally leave part of the gestation inside the uterus, and we call that retained products of conception, and that can cause infection risk, um, and lead to maternal sepsis. So we definitely don't want that. So it's actually easier if you get everything out in one piece. So that is a myth that is largely untrue. So the manual vacuum aspiration is usually used kind of earlier on. And that's where literally they dilate the cervix and they just go in with little suction and they just kind of suction stuff out. This one right here, D&E, is fairly similar, but is usually done in an operating room, and you have to do a bit more to dilate the cervix in order to get the products of conception out. So, talking about the safety here. So, D&E is a safe and common method of second trimester abortion. Dilation and evacuation is a surgical abortion procedure that takes place after the first trimester of pregnancy. Similar to a first trimester surgical procedure, the patient's cervix is dilated and suction is used to remove the fetus. Depending on a variety of factors, including gestational age, the extent of dilation, and provider's training, the provider might also use surgical instruments as a primary or secondary part of the procedure. 11% of abortions in the United States take place after the first trimester, and national estimates suggest that D&E accounts for roughly 95% of these procedures. The safety of the D&E method was documented in the late 1970s. According to ACOG, D&E is the predominant approach to abortion after 13 weeks and is evidence-based and medically preferred because it results in the fewest complications compared to alternative procedures. So this is completely uh, like if we're comparing the risks and benefits, even the risks of having a D&E are significantly reduced compared to the risks of having a full term delivery. Um, so they go into some of the arguments on partial birth abortion, and this is again similar to late term abortion. Partial birth abortion is ridiculous as a concept. This is not done because if an abortion is the ending of a pregnancy and birth is an ending of a pregnancy, you're having a partial ending of a pregnancy, right? If a birth and something here, birth does not necessarily imply that the fetus is alive, right? So again, going back to how nebulous these definitions are and how people are using terms all willy-nilly without really thinking about what they mean. A birth, you can have a stillbirth. A stillbirth is the birth of a non-viable fetus. So if you define a birth as let's see, I don't even have the definition of birth pulled up, but let's do it. And of birth. The medical definition is birth, the process of bringing forth a child from the uterus or womb. And okay, well, since we also often define a C-section as a birth, I don't know. The term birth really isn't used medically much because we'll refer to it as a delivery. Um, I think just because the term birth can be so nebulous. Like if a C-section is a birth and a vaginal delivery is a birth, birth is just I think just a synonym for a delivery. So and if we define a delivery as the like removal of a pregnancy, like the ending of a pregnancy after 20 weeks, then a partial birth abortion is a partial ending of a pregnancy during an ending of a pregnancy after 20 weeks gestation. So I'm just very confused by how this term is even supposed to work. But they say in the 1990s and early 2000s, state efforts to restrict access to abortion after the first trimester coalesced around bans on partial birth abortion, an inflammatory term coined by the anti-abortion group National Right to Life that has no precise medical definition. Yeah, exactly. Many, but not all of these state level restrictions were struck down by courts until the Supreme Court upheld a federal version in Gonzalez versus Carhart in 2007. The law bans partial birth abortion except when the person's life is endangered. The court found that provocatively worded but medically imprecise definition of the procedure sufficient to pass constitutional muster and applied it to the dilation and extraction DNX abortion method. In doing so, a majority of the court reasoned that women could still have access to the safe and effective D&E method. Interesting. So the court ruled that you're not allowed to dilate the cervix and go in and use forceps to extract the products of conception, but you can have access to the safe and effective dilation and uh, evacuation, which is more done with suction than with forceps, but can use any combination of the above. Like these are DNX and DNE are largely the same procedure. So the fact that the inflammatory language caused them to allow one and ban the other when there's really no significant difference between these two, it's just showing how this was based on emotional responses to this term partial birth abortion and not at all about the safety of termination or anything related to fetal perception of pain or any of that garbage. It was just in response to the emotion. In response to the decision, ACOG stated that the Supreme Court disregarded medical consensus that the DNX method is safest and offers significant benefits for women suffering from certain conditions, and further noted that the ban diminishes the doctor patient relationship by preventing physicians from using their clinical experience and judgment. Current efforts to restrict D&E adhere closely to the partial birth abortion ban playbook. Yeah. So this leads into another topic of discussion that I think we'll get into after we address this other article. So we're going to talk about why do people get terminations, especially why do people get terminations after 20 weeks? And so this is an article from the UK specifically. So the statistics are reflecting the UK, but pregnancies happen in all different countries, of course, with different risks based on their healthcare systems. But what they say in here is pretty similar to what we would expect in the US as well. So here we go. So in the UK, the vast majority of abortions happen early. In 2018, 91% of all abortions took place in the first trimester. The proportion of later abortions, defined here as abortions taking place at 20 weeks gestation or later, is consistently extremely small, between 1 to 2%. So here they show the rates. So between weeks 3 and 9, you have about 80% of abortions taking place there, about 10% occurring between weeks 10 and 12, less than that, less than 10% for weeks 13 and 19, and then like 1 to 2% for 20 and over. So they say around 1 in 3 of women seeking an abortion after 20 weeks do so because there is a serious problem with the development of the fetus, often during the course of a very much wanted pregnancy. So oftentimes this is a very difficult decision for people to make because they wanted to carry that pregnancy to term. They were planning on it. And then something came up where this fetus was no longer viable or had very poor chances of a positive outcome. And so they have to make the decision of, do they want to take the risk and see how it goes? Or do they want to terminate the pregnancy? So that's the majority of the cases having second trimester abortions. And so this particular charity kind of studied individual responses and their particular reasons for presenting later. So the number one they say here was for fetal anomalies. So they say that the variety of conditions that were listed here include neural tube defects like spina bifida or anencephaly. Anencephaly being a condition where the head just does not develop. So that is not viable. Congenital malformations of other systems or organs, including cardiovascular, which there are so many ways that the heart can misform. And if you think about what is going to, like, let's say the fetus has a cardiovascular condition that is partially viable. Like, there are a lot of conditions where, like, if you understand the venous and the arterial system, you have parts of your heart that are supposed to pump deoxygenated blood to the lungs to get filled up, and then that blood goes out to the tissues. So you can have cases where those blood vessels are transposed, or where you're supposed to have veins, you actually have arteries, and where you're supposed to have arteries, you have veins. So in that case, you're pumping deoxygenated blood out to the tissues, which can be viable in utero because they don't need those they don't need their cardiovascular system to function perfectly because their pregnant parent does that for them. And they have a number of different shunts that, like for example, that you have the foramen ovale, you have the ductus arteriosus that cause redirection of blood throughout the system so that you, no matter what, you're going to get oxygenated blood out to the fetal tissues. So you have this fetus that is viable while they're in utero, but as soon as they exit the uterus, they might die very quickly because they can't get blood to their other organs. Let's think about what is required to keep this baby alive after a full term delivery in that case. They're probably going to need a very, very extensive open heart surgery uh, to like permanently correct that, or and possibly leading up to it, they might need to be on something like ECMO or something that pumps blood around their body for them or oxygenates their body for them, which is very, very painful, very, very expensive. Let's think about those expenses for a second. So you're paying for uh, the care leading up to the surgery, which hospitalizations cost a lot of money. And if you're in the hospital ever since birth, like I remember the one of the 23 weekers that I was taking care of at the children's hospital had like was in the NICU for an extended period of time and then finally went down to the step down unit, um, requiring pretty much constant sedation and needed feeding tube, needed breathing treatments, all this stuff. Was in the hospital at that point for about 6 months. So from their entire time being alive, and that medical bill, like there was an actual committee at the hospital that meets to talk about like high cost cases and what they can do about them. $2.6 million for that baby's hospital care up to that point. So this is not low cost stuff. And if we think about right now, where people are losing their access to health insurance, how are people supposed to afford a $2.6 million hospital bill just for the 6 month stay? And that's going to be even more afterwards because that baby's going to go home and going to require chronic management of all these conditions. So back to kind of the heart example, you've got the care leading up to the surgery, you got the surgeon's cost, you got the anesthesia cost, you have in addition to, all of the costs of the delivery and the pregnancy is not cheap. If you have an uncomplicated pregnancy, you're still looking at 20,000, like somewhere between 10 and $20,000. If you have a complicated pregnancy, you're looking at more, probably upwards of $60,000. So how are people supposed to pay for this stuff? So if you get an ultrasound earlier on in the pregnancy, which they do frequently during prenatal care, if someone's faced with that decision, it may be the most reasonable and ultimately the safest decision for all parties to terminate the pregnancy at that point. Like if you uh think about the capacity for pain that a a newborn baby is going to feel, or even a, like, let's say this baby lives longer into a few weeks, a few months, a few years. Let's say you have a 2-year old that has this uh I mean, if they're living to 2, they probably have a pretty significant chance of survival, but let's say you have a newborn that would have to experience all of this pain, and suffering of dying from a heart condition that the parents can't afford surgery for. Which is the more humane option? To get a termination at 21 weeks gestation, or letting that child die from a heart condition that they can't fix? Like, these are clearly very, very different, and probably a very hard decision for the parent to make. But that is what we're talking about when we're saying this. There are reasons why this may be the better option for some people. So some other conditions they mention, uh, Yeah, so they just list the percentages. So 21 percent of the people they surveyed were for nervous system uh, abnormalities. 27% were for congenital malformations of other systems or organs. 33% were chromosomal anomalies, and 18% for non-specific other conditions. And so the chromosomal anomalies were screened between 10 to 14 weeks of pregnancy. And then a lot of the stuff that you're going to see, you don't actually have evidence for until around 20 weeks gestation. So that's the point where they're going to find out and then may need termination at that time. Change in circumstances. So another reason why people may need to terminate. This person in the example, client lost her partner to a serious illness a few weeks ago, suffers from complex mental health issues, and has a physical health condition that means this pregnancy is high risk. So this person would have to make that decision of, is it more humane to end this now or allow things to get worse by carrying to full term? Uh, Client is 22 weeks pregnant. Partner has just left her with significant debts, feels financially and emotionally unable to have a baby. So that like these cases where circumstances change. Domestic abuse is a big one. So they have so evidence suggests that around a third of domestic violence cases either begin or worsen during pregnancy. Escalation of violence may be a major factor in their decision to terminate, as they worry for their ability to escape an abusive relationship with a child and for the safety of that child. Absolutely important to think about that. Health problems. Sometimes poor physical and mental health can prevent a person from continuing with a pregnancy. This could be the sudden onset of an illness, a gradual deterioration during the course of the pregnancy. Ending a pregnancy for health reasons can be difficult to come to terms with, but some women, in consultation with their doctor, will decide that this is the best path for their situation. Yes. Welcome, Ryan. It's okay. It's okay if you're late. This is one I recommend everybody go back and watch the beginning of this and like share this one out. We go into a lot of nitty-gritty arguments today on this. When they go into some of the issues that I addressed earlier on, so things like poorly controlled diabetes. So diabetes during pregnancy is very, very, very high risk. Epilepsy, if you have epilepsy, and then compound that with risk of preeclampsia or eclampsia. If we remember, eclampsia is seizures during pregnancy caused by high blood pressure. You could make that worse. You could cause permanent brain damage for both parties. Asthma, high blood pressure, as we discussed, thromboses, so blood clotting issues, sickle cell disease, hemophilias, stroke, brain tumors, placenta issues with the location of the placenta. Those are all reasons why somebody may need to terminate after 20 weeks. So, because something along with that, 20 weeks is where you start learning about your risks for hypertensive disorders. So if you have hypertension before 20 weeks, usually that's considered chronic hypertension. So that's not related to placental blood flow. And that's separate from preeclampsia risk. But after 20 weeks, if you start developing high blood pressure, that is really worrying that you're going to develop preeclampsia or eventually eclampsia or something like HELP syndrome, which is an issue related to low platelets and liver issues. So you face risks, like very, very high risks of hemorrhage. We have to take very specific precautions trying to protect brain health in that case and protect people from hemorrhaging and dying. So lots of scary things here. Yeah, and some examples here. Client with children had serious liver condition and approached us at 19 weeks of pregnancy for a termination. She had to receive treatment in a hospital setting due to her complex medical needs, for which she had to wait 4 weeks for an available appointment. So in that case, she probably wanted the termination earlier, but couldn't get it because of appointment availability. And so then that put her around that 20-week mark. So things that are important to consider there. Any questions inside chat about any of that stuff so far? We're probably gonna run over time today because there's just too much. There's too much to get into here. As like I said, I have so many tabs open right now. Um, unless another option. So I'm actually gonna put this question to side chat. Do we want to spend more time here today to continue talking about well, I think we are going to hit on ectopic pregnancies today. But do we want to hit on medication abortions today, or do we want to do a separate episode talking about misoprostol and mifepristone? Because we could very easily spend an hour and a half just talking about that topic. And I think we're not even going to get into contraception today. Because that we'll spend a whole other day on contraception as well. But let me know in the side chat right now what you want me to do, and we'll go with that. And in the meantime, we didn't even get through all 10 of the myths that we saw. Most of them are okay. We'll quickly go through the list of myths we didn't get to. Myth number 4, that women who seek abortions are irresponsible. We've already gone over so many things, so many reasons why people get terminations. And actually, this is a great point to jump in to talk about ectopic pregnancies. Yeah, Calasia, I think you're right on the nose there. We might need to spend a whole other time talking about that. So this brings up the issue about okay, we are going to talk a little bit about contraception, but in the context of ectopic pregnancies. So, yeah, a lot of people think that people are using abortions to function as birth control, and that is not true. And you know what would improve this? Like, even if this was true, what would improve people not going? What would make people stop going to get abortions for the purpose of birth control is allowing safe and effective birth control to be accessed by everybody. That would help. But contraception isn't always effective. Like, it's not 100% effective. There are certain methods that are very, very highly effective, such as the combination pill. Even the mini pill is pretty effective, but maybe a bit lower tier than the combined. You have IUDs, specifically the hormonal IUDs are very, very effective. You have the Nexplanon, which is the implant that goes in your arm, super duper effective. You have some things that are less effective, like the patch, the NuvaRing, the Depot. We're even going to go into a whole episode about the Depot because there's a lot of information going around right now about that particular issue. But there are risks, whatever contraceptive method that you use, there are risks that it is not going to be effective. And there are risks of ectopic pregnancy with contraception use, and especially predominantly with IUD use. And so we just to clarify on this, that I'm not saying that having an IUD means that you're likely to get an ectopic pregnancy. That's not at all the case. You have such a decreased risk of pregnancy in general from a hormonal IUD. But if you were to have a breakthrough pregnancy with an IUD in place, you're more likely that particular pregnancy is going to be ectopic. And so when we say ectopic pregnancy, that is a pregnancy outside of the uterus. So that can be most commonly in the fallopian tube. It can be actually in the abdomen. There are cases of people who've had ectopic pregnancies in their liver. It's pretty It's pretty wild. And there is a like this concept that like sperm has evolved to find a way. It's it it finds a way in the most unexpected circumstances to fertilize an embryo. And so I was actually watching an OB um, on her YouTube, and she was going over a case report from 1988 that was like absolutely wild. Uh, so there's a patient who was born without a vagina and didn't know that until kind of later on, but learned that she couldn't have vaginal intercourse effectively because she does not have a vagina that connects from the outside world to the uterus. And so she was under the assumption that she was not going to get pregnant because of that reason. But also, like this is so wild. So she was having oral sex with her partner. So like another reason why she wouldn't be likely to get pregnant. So she's having oral sex and then gets stabbed. I think it was by her partner, uh, like stabbed her in the abdomen. And then that's like, sorry to get graphic, but that sperm in the abdomen got out into the peritoneal cavity and eventually like into the pelvic space and fertilized an egg. She was ovulating at that time and had an ectopic pregnancy in the abdomen from oral sex and then being stabbed. So like, sperm loves to find a way. Like, and that's a very wild, like one-off example that is, of course, isn't super common. But these things happen. These things happen that you don't expect. And the only way to manage an ectopic pregnancy is through surgical removal. And especially when you have an ectopic pregnancy located in the fallopian tube, you risk rupture of the fallopian tube. In that case, where it was in the liver, you risk a baby growing inside of the liver, which is absolutely wild. Like, how are you going to deliver that? Deliver, pun not intended, but how are you supposed to survive that situation? Um, and yeah, I'm sure like that livers can regenerate. Livers are very resilient, but how do you expect that person to carry their liver baby to full term? That is absolutely ridiculous. Um, so getting into some of those like ectopic pregnancy myths really quick. Is it? That's not that one. Mm, okay, here we go. Again, from ACOG, understanding ectopic pregnancy. So an ectopic pregnancy occurs when a fertilized egg implants and grows in a location that cannot support the pregnancy. Almost all ectopic pregnancies, more than 90%, occur outside of the uterine cavity in a fallopian tube, but they can also implant in the abdomen, cervix, ovary, and even a cesarean scar. So, like if someone had a C-section before, you can get that pregnancy to implant inside like the abdominal wall, which isn't going to work super well. I don't think the placenta is going to develop very well there. Where an ectopic pregnancy in any location is life threatening. This is because as the pregnancy grows, it can cause the structure where it is implanted to burst or rupture. A rupture can cause major internal bleeding and is a life threatening emergency that requires urgent surgery. A tubal ectopic pregnancy will never be viable. So, this is very, very important. It will never be viable. It cannot be moved. It cannot move or be moved into a place in the uterus where it can grow safely to delivery. So there are only two options that you can do. It's create a tubal ectopic pregnancy, medication, and surgery. So the question from Ember, is it the eggs that escape into the abdomen usually, or is it the whole fertilized zygote that jailbreaks? So it's usually the uh the ovum that escapes of the abdomen. So fun fact, the fimbriae of the uterus are what pick up the ovum. There's no direct connection, and this is like great design if this is designed by a god, but there's no direct connection between the ovary and the uterus. Like the ovum has to travel into the abdomen and hold like grab onto the fimbriae and then be transported inside to the fallopian tube and into the uterus. So you could have what usually happens in that case, you have the sperm that like gets lost, swims up, and like will escape. Like oftentimes it'll meet up with the ovum like in the fallopian tube. But if it's going to be an abdominal ectopic pregnancy, like this little sperm gets lost trying to find the ovum, exits the fimbriae, goes into the abdominal cavity, fertilizes the ovum, and implants somewhere. It's absolutely wild. Like if you were going to say that this is like the way that humans come about, why would you not connect the ovary to the uterus directly? I just I don't know. Maybe I need to make a little short video on my series about the human body is so poorly designed. But that is one example, another example of where this is so poorly designed. Um, but yeah, so the important point here is that the only thing you can do about an ectopic is to terminate the pregnancy through surgery or through medication. And these methods that are used to remove the ectopic are the same methods used to have an elective termination. So this is where laws get very dicey. If you start outlawing these things, where are your cutoffs? Where are the boundaries? And why are politicians deciding what those boundaries are? Um, like, is a politician going to take full responsibility for missing an ectopic pregnancy and having a person die? If they are so eager to make medical decisions for other people, they should be just as eager to take responsibility for said uh, outcomes of that medical decision making. So it's true that doctors aren't perfect. There are times when a seasoned board certified OBGYN is going to miss an ectopic pregnancy and uh, cause patient harm and possibly mortality. But the likelihood of that happening under physician guidance is way less than with a politician just deciding arbitrarily based on some inflammatory language that that gets to happen. So I think we should be holding our lawmakers more accountable. I think liability is a very, very powerful motivator. And I think that that's a factor that is going to impact AI in medicine as well, but that's a separate topic. But I think if we said, "Hey, Texas politicians, you can make decisions, you can make these medical decisions for other people, but you have to take full responsibility for what happens when it goes wrong. You get the malpractice suit. You get your career taken away. You get to go to prison, all that stuff. You get to follow those rules." Then see how much they try to defer that responsibility to somebody else, right? Like this is what we saw with RFK Jr. and continue to see with him is the idea that, oh, well, don't take medical advice from me because I don't know. No, but then he's going out there trying to make medical decisions. Like, okay, so you're gonna say don't take medical advice from you when your feet are held to the fire. But as soon as you feel like your feet aren't being held at the fire, you feel like you have every right to make those decisions on behalf of other people. And that is absolutely astounding to me. Right. Miranda is saying it's almost like we should let doctors practice medicine and patients make their own decisions. 100%. And so I think this is where we're gonna leave off for today. We will get into medical abortion later on, probably in a month or so, because we have a few guests coming up in the future. So don't miss the guests. But we're gonna have a separate talk about all this. Um, but this issue is it's so painful to me because People have no idea what they're talking about. They have no idea how to manage a pregnancy. They have no idea how complicated any of this is, and they think it's just a simple binary question of have the baby at term or be a degenerate and get a termination. But today we talked about a lot of reasons why people need these procedures and why they should be freely available. And I want to point out that ultimately, ultimately, the argument from for bodily autonomy is very, very, very important, and we should use that argument when talking about the morality of this issue. However, I think we are putting ourselves in a disadvantageous position by only arguing that. I hear a lot of people doing a great job arguing from bodily autonomy. But I think without having this knowledge about the decisions that have to be made, the statistics, the reasons why people may get a later abortion as opposed to an earlier one. Things like we discussed about costs for managing chronic congenital heart defects and what that's going to do. $2.6 million hospital bills for a single mother with a child that was born at 23 weeks gestation. We have a lot of misinformation on what termination is, misused language on saying post-birth abortion, which is nonsensical. The language that we addressed with aborting a fetus moments before birth. We need to do a better job of not just saying bodily autonomy, bodily autonomy. We need to push back and say, your facts are wrong. Your arguments are causing people to die. This is a health emergency. We need to lean more on those arguments as well. So this is why I've done so many talks about this particular subject, because I think we do need more ammo in our back pocket. And feel free to use, obviously, you're here watching this. I put this content out for a reason. Use these arguments in conversations, test drive them a little bit. Think about these for yourself. How would you feel in these specific circumstances? If you had to make that decision of carrying a fetus that you wanted to carry to term, to find out that you don't have the resources or health insurance to afford their care, what would you do in that circumstance? How should doctors think about weighing out these risks and benefits? How can we enforce some of these policies? I think these are very, very important things to consider. And please share this out. And we got a super chat from Kelly. This conversation was very much needed. I appreciate you for speaking up and giving people medical facts. Thank you so much, Kelly, for being a supporter and for hanging out. I promise we will come back and talk about medication abortion in the future. But with that being said, a couple announcements for the upcoming week. So we will not have medical myths this upcoming Saturday because I will be driving. And actually, Miranda, I'm going to talk to you because I might be driving towards you. Maybe we can meet up or something. That might be fun. So I'm not gonna dox you on the air. But we can chat offline. And Miranda giving a $10 super chat. Thank you for a super informative show. Thank you so much for being here. But we will be having trivia this week. We have Star Wars tomorrow. We've got trivia on Friday, and just no medical myths. I think I will have I think I'm going to release a recorded video. So stay tuned. I think I'm going to release one of the calls from Takis this past week. So please watch that, like, share, all that jazz. But then we'll be back on the 7th. We're going to be back on the 7th with Chad. So I'll tell you about the guests that we're having this next month. We're on the 7th of February. We're going to have Chad on talking about the IBLP and how they taught their homeschooling program about science and medicine. It's wild. And then the week after that, on the 14th, Cynthia McDonald is going to be here talking about HIV stigma, and how we can better uh, be allies and better supporters for people who are living with HIV. So it's going to be a really great time. Thank you, everybody, for sticking around. Stop by for Star Wars tomorrow, and I will see you all in the next one.